Order, please. Good afternoon. This is the Standing Committee on Health. In the absence of a chair and vice chair, the committee needs to elect an acting chair from among the members that are present. For the purpose of today's meeting only, the floor is now open for nominations. Ms. Miller? I nominate Keith Irving. Okay, with that, Mr. Irving will chair today's meeting. Okay. Go ahead. What's that? You should ask if you have to have a vote. Sorry. Are there any other nominations? Okay. With that, Mr. Irving will chair today's meeting.
Thank you very much. Welcome everyone to the Legislative Assembly here and the Standing Committee on Health. Today we will be hearing from Dr. David Anderson and the Dean of Medicine at Dalhousie University, and as well Dr. David Gass, the head of the Department of Family Medicine, both from the Dalhousie Medical School, and we'll be discussing its role in healthcare sustainability. So welcome to our witnesses today. A reminder for everyone to have your phones off or on vibrate, and in case of emergency, please exit through the back door to Granville Street and gather across the street. And so I'll now ask our committee members to introduce themselves and their constituency, and perhaps we'll begin with Ms. Martin.
Thank you and good afternoon. Tammy Martin, MLA, Cape Breton Centre.
Good afternoon. Susan LeBlanc, MLA for Dartmouth North.
I'm Barbara Adams, the MLA for Cole Harbour Eastern Passage.
Great to have you here. Carla McFarland, MLA for Pictou West.
Margaret Miller, the MLA for Hands East.
Labi Kasoulis, MLA, Halifax Citadel, Sable Island, and Minister of Labour and Advanced Education.
Good afternoon. Glad to have everybody here today. Bill Horn, MLA for Waverley Fall River Beaver Bank.
Welcome. Hugh McKay, MLA for Chester St. Margaret's.
Great, thank you all. I'll now turn it over to our guests to provide a few opening comments. Turn the microphone, I guess, over to Dr. Anderson.
Thank you very much, Mr. Chair. Thank you for inviting us to appear before the committee today. My name is David Anderson. I'm the Dean of the Faculty of Medicine at Dalhousie University, and I'm pleased to be joined by Dr. David Gass, who's the interim head of the Department of Family Medicine at Dalhousie University. Dalhousie Medical School celebrated its 150th anniversary in 2018. We have a long-standing tradition of producing excellent physicians, performing world-class research, and contributing to our communities and society. I will briefly focus on some of our efforts in each of these areas in my presentation. Our medical school currently trains 108 medical students per year in our 4-year undergraduate program, 78 in Nova Scotia, 30 at our Dalhousie Medicine New Brunswick campus. This number will rise to 124 students next year with the recent announcement of the expansion of the medical school class by 16 Nova Scotian students. At Dalhousie, we are committed to producing medical graduates that meet the needs of our province. This has resulted in 2 significant strategic shifts in undergraduate medical education over the past few years. First, we recognize the need for family physicians in Nova Scotia, and as a result, we are producing a much greater emphasis on our training in family medicine. Our goal is that 50% of our graduates will pursue careers in this discipline. Over the past year, we've seen the number of our graduating students selecting family medicine residencies increase from 25% to 40%, and we look forward to seeing this figure rise in upcoming years. Second, we recognize the need for physicians outside of the urban Halifax area. As a result, we're providing our students more educational opportunities throughout the province of Nova Scotia. For example, we're excited that in September 2019, for the first time, 4 medical students will be spending their entire third year of medical school training under the direction of physicians in Cape Breton in our longitudinal integrated clerkship program. Our goal is that 1/3 of our students will participate in longitudinal integrated clerkships around the province over the next 4 years. Dalhousie Medical School also trains graduate physicians to become family physicians and specialists. We have over 50 residency training programs, and currently we're training over 500 residents across the Maritime provinces. In family medicine, we have 5 sites in Nova Scotia that train 46 residents each year in a 2-year program. This includes a new site in the North Nova region that is training 6 residents in Truro, New Glasgow, and Amherst, which opened July 1st, 2019. Other family medicine training programs are based in Cape Breton, the Annapolis Valley, Southwest Nova, and in Halifax. Also, on July 1st, 2019, 15 new specialty residency positions were opened to address the specialty needs of communities outside of Halifax. Given our students and residents' learning experiences outside of Halifax accomplishes 2 major goals. First, it provides them with excellent educational experiences. Second, it attracts our graduates to live and work in community settings around our province. Students and residents are now being trained to work in areas around the province that needs them the most. Research is an integral component of Dalhousie Medical School's mission to advance quality of health and health care in the Maritimes and beyond. Not only does research lead to a better understanding of the prevention and treatment of disease, it also provides healthcare providers and policymakers with information that is essential for making real improvements to clinical practice, health service delivery, and public health policy. Over the past 5 years, the faculty of Dalhousie Medical School has received over $300 million in research funding, accounting for about 40% of Dalhousie's total research funding. This is the largest amount of research funding awarded to any faculty in any university in Atlantic Canada. Our researchers are not only finding innovative solutions to address important health issues facing Nova Scotians, they are creating jobs and positively impacting our economy. Furthermore, having a medical school with excellent educational programs and research opportunities is key for the recruitment and retention of family physicians and specialists who make up our university faculty and play such an important role in healthcare in our province. The quality and breadth of care these physicians provide make it an uncommon event for Nova Scotians to have to leave the province to seek care for medical services not available provincially. Dalhousie Medical School also has a major societal role to help address the needs of underrepresented groups. We are increasing our efforts to recruit and retain more diverse medical students, including Nova Scotians of African descent, Mi'kmaq, and other Indigenous groups. Over the past 8 years, Dalhousie Medical School has had an affirmative action program that supports the admission of Nova Scotians of African descent and Indigenous students. This year, we are welcoming 6 Nova Scotians of African descent and 5 Indigenous students into our first-year class. The Faculty of Medicine is directing its focus on the admission of status Mi'kmaq students. Our affirmative action programs have to date resulted in us recruiting a very small number of status Indigenous peoples and no status Mi'kmaq students from Nova Scotia. Addressing this issue has become the focus of our social accountability and admission teams. Dalhousie is also committed to ensure that students throughout Nova Scotia have the opportunity to attend medical school. With the addition of 16 seats, we are committed that our students in Nova Scotia reflect the population balance between urban students in the Halifax region with those from communities around the province. A focus on diversity, equity, and community representation will lead to improved and more inclusive health care for all. Teamwork is an important component of running our medical school. Our clinical faculty in Nova Scotia all have appointments with either the Nova Scotia Health Authority or the IWK. Much of our training and research occurs in NSHA and IWK facilities, and we rely on the excellent collaboration and support of these organizations. I also want to credit the Department of Labor and Advanced Education and the Department of Health and Wellness for their roles in supporting our work. We also work closely with Doctors Nova Scotia and the Provincial College in efforts to support the training of physicians in our province and in innovative programs such as the Family Medicine Ready, Practice Ready Assessment Program. We are well aware of the challenges facing the Nova Scotia healthcare system, and with the continued support from government and our partners, we will continue to produce excellent medical practitioners to help the needs of society and contribute to a strong and sustainable healthcare system for Nova Scotia. Thank you very much again for the opportunity to speak with you here today, and we look forward to answering your questions.
Thank you very much, Dr. Anderson. I've just been made aware of a legislative rule here, 5A, with respect to, well, I'll read the rule. With the exception of the Attorney General, who shall serve as chairman of the Law Amendments Committee, no minister shall be appointed to a standing committee established for the purposes of considering matters normally assigned to or within the purview of that minister or that minister's department. It's a bit of a gray area. Like comments from the committee, we have Minister Kasoulis, who is responsible for universities, but the topic is with respect to healthcare sustainability. He's not the Minister of Health. I'd like some opinions from the committee on whether we'll allow Minister Kasoulis to remain, and then I will make my decision. Are there any concerns with Minister Kasoulis being here? Ms. Adams.
I think given the importance of the topic that we would value his input, and so I have no objection to him remaining.
Thank you. Any other comments? Minister Miller?
Yes, I believe that Minister Kasoulis can add to this conversation as well. We'll have some good questions, so we actually also value his input in the committee.
All right, thank you. And with that advice to the chair from committee members, we will proceed. So with that now, we will now move to questions from the various caucuses, and we'll begin with the PC caucus for 20 minutes. Ms. McFarland.
Thank you very much, Mr. Chair, and thank you so much for that input. Thank you for being here today as well. And it's great to know that Dalhousie, 150 years, that was quite a celebration. And we thank you for all the hard work that you've been doing. It doesn't go unnoticed. I want you to know that, and we're very proud that Dalhousie is in Nova Scotia. It's worldly known, and I've had a lot of relatives go there over the years, and very proud to have it here. Look, we are entering a very delicate time in our healthcare system. And myself, coming from a rural area like Pictou West, there's many of us, including myself, that don't have a doctor. Thousands and thousands, to be honest. So I think one of our biggest concerns and questions that I hear a lot from constituents is, why are the doctors that are graduating from Dalhousie not staying here? Why do they exit? So I'm just wondering if you could give me a bit of feedback on why you think they're exiting and leaving this province and not staying here to practice.
Dr. Anderson.
Thank you very much, Ms. McFarland, for the question. I would tend to look at things a little bit differently in framing a response here, and I think what I would like to focus on is what we're doing to try to keep Dalhousie doctors here in Nova Scotia and to have them live and work here. So two factors that are very important in the recruitment and retention of physicians, particularly in community settings outside of Halifax, outside of our major urban setting, are providing the students with training experiences in the community. So we are doing that in two major ways. First is in our undergraduate, in our medical school program, which is a 4-year program. The medical students, we have developed a program where students are spending their entire 3rd year of medical school, which is really their formative year where they interact with patients, work in hospitals, work in clinics, interact with family physicians and specialists or under their supervision. That we have developed a program and which is called the Longitudinal Integrated Clerkship Program, where students are spending that entire year in the community setting. We have experience with this program in our Dalhousie Medicine New Brunswick campus, where 50% of our students are trained outside of St. John, New Brunswick, and we're opening our first longitudinal integrated clerkship program next month in Cape Breton as a start to get our students out in the community for their training. And our target is that a third of our students, or probably 30 of them, over the next 4 years will receive this formative clerkship experience entirely in the community setting. The reason that that's important is that students, evidence would show elsewhere in the country and around the world, that students that receive this type of community training are highly likely to enter community practice when they finish their graduation, when they become physicians. And whether it's family physicians or specialists, there is a high likelihood that physicians that are trained in this type of program will work in a community setting when they enter practice. So our efforts now are to maximize that opportunity around the province, provide our students with that great educational experience and to have them to be attracted to work in the community setting when they're finished their training. We also have family medicine residency training programs. So, and Dr. Gass can certainly speak to this as the head of the department, but we train in training our graduates to become family physicians. We have 5 of these programs in Nova Scotia. 4 of them exist in communities around the province. In Cape Breton, in the North Nova area, which is Truro, Amherst, and New Glasgow, in Southwest Nova in the Yarmouth region, and in the Annapolis Valley. So again, these residents now, the graduate physicians, are provided with training experiences in the community to immerse them in the community and to attract them to take up residence and to work in those areas when they're finished. And our data has shown that when over the past 5 years, when Dalhousie graduates enter our family medicine residency training programs, one of those 5 programs, we have an 83% recruitment rates. So 83% of our DAL grads that are entering those family medicine residency training programs enter practice in Nova Scotia, as compared to only about 50% if the graduates come from other medical schools and do their residencies at DAL. So those students are much more likely. So by having more DAL students doing more residencies, and with our efforts here on distributed educational programs, we believe we're going to continue to recruit and retain more physicians in this region in the years to come.
Ms. McFarland.
Thank you, Mr. Chair. And just given the limited amount of time we have, I will try to get to my questions as direct as I can, and perhaps may inject once in a while too, so that I can move on to the next question. So as of today, as we speak right now in Nova Scotia, we have 185 unfilled doctor positions in Nova Scotia. Can you tell me why you believe we have 185 unfilled positions?
Dr. Anderson?
So in partnership with the Nova Scotia Health Authority, with the IWK and the provincial government, we are working and doing what we can about recruiting and retaining physicians in our province. We think that's a very positive development. The Nova Scotia Health Authority has hired a physician recruiter, or is hiring a physician recruiter that's going to be working with our graduates about looking to find places for them to work and train when they are finished their training. And we want to make it as attractive as possible to keep graduates and physicians that are coming out of our program in Nova Scotia. And I think it is paying off. Our data would support that things are moving in the right direction. With the increased medical seats, the increased residency training programs, we are going to producing more physician graduates to work in our province.
Ms. McFarland?
Just quickly, how do you think it's paying off when we have anywhere from 60 to 100,000 people without a doctor?
Dr. Anderson.
It's incremental gains. I think it is our role, and our role in the system is looking at the moderate and the long-term solution to sustainability of healthcare. So by producing more graduates, by recruiting more young people and having them stay in our province to work is going to be part of the solution of addressing the shortages that you point out.
Ms. McFarland?
Thank you, Mr. Chair. So we live in a province of less than 1 million people, and let's say you have 12 individuals that graduate at the same time. So their credentials are obviously, let's say they're the same. What we're finding right now, as we speak today, we have 11 ER closures in this province. And we have 4 different zones. So the doctors that graduated together, if we have a doctor working in an ER in Yarmouth that wants to go to Cape Breton as a locum to go work there while someone goes on vacation, they have to go through this amount of paperwork in order to ensure that their credentials meet that zone. So we have 4 zones, and it's really frustrating to see that system, that policy is in place. I'm wondering if you have a comment on that, and if you feel that that is a necessary step that has to be taken for doctors to move in their own province to work at other facilities.
Dr. Anderson.
Yeah, I work closely with colleagues at the Nova Scotia Health Authority, with Doctors Nova Scotia, at the Provincial College, and with government. That specific issue is not under my domain to manage or to deal with. I have the confidence everyone has the best of intentions to make this provincial healthcare system work, and would support that I think those are good questions to ask those individuals, but I think they're doing their utmost to work in improvements in health and healthcare delivery in the province.
Ms. McFarland.
Thank you so much for that answer. So you indicated that we have over 50 residency training programs and are currently training over 500 across the maritime provinces. Do you have a breakdown of those 500?
Dr. Anderson?
So I don't have the breakdown of those numbers in front of me, but I'd be happy if that would be information you'd like to see, be happy to provide that information to the committee.
All right, thank you, Dr. Anderson. Please bring that or send that on to us following the meeting. Ms. McFarland.
Thank you, Mr. Chair, and thank you. We would look forward to that information later on. So I'm just wondering how many Dalhousie graduates has the province of Nova Scotia actually retained in the last, 5 years?
Dr. Anderson?
Yeah, so it's a very important question. Since 2010, we have embarked on a project which is called the Located Project, where we are tracking the path of every graduate of our program. So in 5 years' time, I'm going to be able to give you a great answer as to where those people are. But unfortunately, it takes time for physicians to develop. So it's 6 years for a family physician to develop, and over 10 years for a specialist to develop. So to systematically give you those numbers, I don't have a robust systematic answer right now.
Ms. McFarland.
Thank you. That's fine. Thank you for that. Do you know, though, even in the last year?
Dr. Anderson.
Again, it's the years don't line up. Like it's doctors go into residencies that are anywhere from 2 to 6 years. So it's a complex answer to a simple question. But what I again would tell you, I think the most robust and perhaps important information for the committee is what's happening with our family medicine residency graduates. So over the past 5 years of the of the family medicine residency training graduates that have trained, that did their medical school training at Dalhousie, 83% of them established a practice in Nova Scotia. If a graduate came from outside of Nova Scotia and went into one of those residency positions, we're retaining about 50% of them. So again, our strategy here for the long-term recruitment and retention of family physicians is to get Dal grads to go into Dal family medicine residency positions and have them stay in our province to work and live when they're finished.
Ms. McFarland.
Thank you, Mr. Chair. There's a number of individuals that I know myself that have been, trained internationally and are wanting to come back home. They want to hang their hat. They want to live here and have a family, and they're meeting a lot of barriers as international graduates. I'm just wondering if you could elaborate a little bit on why you think it's so difficult for them to find residency programs.
Dr. Anderson.
There are residency positions available for international medical graduates, and in our Dalhousie Family Medicine program, we have 6 designated seats for international medical graduates, so they can apply to those positions. Those residents or those graduates are also eligible to enter what's called the second iteration of the matching process, of the residency matching process. And last year there were 4 international medical graduates that joined one of our family medicine programs through that match. So 10 international medical graduates have come to Dalhousie programs, family medicine programs, over the last year to begin training. We also have 2 positions available within our medical schools so that international medical graduates can come to medical school and do their 3rd and 4th year of training and then graduate from Dalhousie Medical School and then pursue residencies from there. And that is also a popular pathway for international medical graduates to look at those opportunities.
Ms. McFarland.
So in saying that, will the addition of residency spaces actually help internationally trained doctors?
Dr. Anderson.
So again, there is a matching process by which across the country, graduates of Canadian medical schools enter a Canadian matching process. At Dalhousie, if there are unfilled residency positions after the first round of the match, which is only open to Canadian medical graduates, then international medical graduates are eligible to apply. And last year, there were 4 international medical graduates that were successful in receiving residency training positions in family medicine at Dalhousie through that process.
Ms. McFarland.
Do you see a need for an increase in residency programs?
Dr. Anderson.
I'll get this cadence right. I'm just so excited to answer these questions here today. I think the members of the committee can appreciate that adding additional residency training positions is a huge undertaking and investment. And we are incredibly grateful to the province of Nova Scotia for adding 25 new residency training positions over the last year, starting July 1st, 2019. And with those additional seats, it does offer additional training capacity for Nova Scotian graduates and for international graduates.
Ms. McFarland, with a little over 2 minutes remaining in your time.
Thank you. So going back to the training capacity, it doesn't give us comfort in knowing, though, that they're staying here, does it?
Dr. Anderson?
So as I indicated, in our family medicine residency training programs, we have recruited and retained over 83% of Dalhousie graduates that have gone into family medicine. So we are being very successful at recruiting and retaining physicians through that program.
Ms. McFarland?
Just 83% of how many?
Dr. Anderson?
Yes, so I have those numbers if you'll give me...
Please proceed with the numbers.
So apologies here. I have 4 different handouts that I'm working from. Yeah, apologies.
Okay, well, perhaps we'll come back to that, Dr. Anderson.
Sorry, here it is.
Okay.
So from 2013 to 2017, there 60 of 72 Dalhousie medicine graduates who did family medicine residency training program have stayed and practiced in Nova Scotia. Of 63 graduates from non-Dalhousie program, who graduated from medical school that the school was not Dalhousie, 36 of those 63 have stayed and practiced in the province. So those are the numbers over the past 5 years.
Ms. McFarland, 20 seconds.
Okay. We know that we have a growing population, an aging population. What is DAL doing in preparation to ensure that we will have, enough doctors? People are concerned for the future and knowing this.
Dr. Order, please. That concludes the time for the PC caucus. We'll now proceed over to the NDP caucus. And Ms. Martin.
Thank you, Mr. Chair. and thank you for being here and providing us with some very useful information. In 2019, in the 2019 hashtag #DalMedForward status update, you indicate that the 2019 graduating class matched only 40% of the students to family medicine. First, if you could clarify how many of those students matched to residencies in Nova Scotia, and how does the 40% match rate to family medicine compare to other medical schools across Canada?
Dr. Anderson.
So I would have to get you that information about the breakdown. It is the vast majority at Dalhousie, but I can get you those figures. Across the country, and it does vary from school to school, that Dalhousie has a responsibility for producing and dealing with all of the physician needs in this province and with much of the physician needs in the maritime provinces. So we are responsible and accountable for making sure we have adequate numbers of specialists and family physicians. There are some schools in the country that work in a province where there may be 6 medical schools, and one particular medical school has a focus in family medicine where 75 or 80% of their graduates may go into that discipline, but there will be other schools in the province where that number will be lower. And the number, it's between 40 and 50% would be typical if we looked at the 17 schools across the country. That information is tracked, however, and I can provide you an exact breakdown to the committee if that's of value.
I think the committee would be interested in that information. We can add that to your list here today. Thank you. Ms. Martin.
Thank you very much. So the status update indicates that the Faculty of Medicine investigated the reasons as to why this match was so low. Can you speak to why Dalhousie medical students are overwhelmingly selecting specialized services rather than general practice?
Dr. Anderson.
Yes, so we did meet with our students and had focus groups to identify why they were choosing not to go into family medicine, and they gave us some excellent feedback about that. One of the issues was around how we organized our medical education. That it is it has been a specialty focused educational experience where most of the lecturers and many of the tutorial leaders and teachers that the students would face see particularly early in their medical school training are specialists. So the students told us they didn't have the mentorship of family medicine early in their sort of formative years, where they often bond with physicians and to say, you know, that's what I want to be. I want to be like Dr. Gass and that sort of thing. So we are addressing that. We are getting our family doctors more involved in our educational experiences early in their training. We are providing more rotations in family medicine, and we now have a mandatory 6-week rotation in family medicine in our first year to ensure that students get early and excellent exposure to family medicine. And we have had a very gratifying uptake of family physicians in the province who are incredibly interested in participating in that program. We also have a week of what's called Rural Week, where at the end of first year, our students go to communities outside of Halifax and work with a family physician for a year. And the students often will say this is their best week in medical school when they go and see real doctors in the community setting, working in real life. So that that has been a factor. Providing our students more educational experience later on and ensuring that in their training in their 3rd and 4th year was also felt to be a gap, and that we did not provide enough educational experiences in the clinical setting in meeting the needs of our students. So that again is something that we're addressing predominantly through this distributed educational program. And we've been working with family physicians around the province, with the College of Family Physicians of Nova Scotia, and have made it clear to them, and they have completely agree that they are the best recruiters for and to attract students to enter family medicine. So again, it's having those role models around the province that are passionate about the importance of family medicine that is an important factor in recruiting physicians to enter this discipline. And the third factor that was particularly an issue 2 years ago is that the publicity around family physicians as being a valued and an important career option for physicians in the media and in physician circles was being questioned, and so again that I think has family physicians, and in dealing with the college and with our Department of Family Medicine, and I would ask Dr. Gass to speak to this as well. You know, our students want positive experiences. They want to be excited and challenged and think that these are great career opportunities for them. And we've sent that message, and it's been well received and embraced by family physicians around the province. So changing the culture and the attitude around the importance of family medicine has been a strategic effort, and with those 3 factors, our students, the number of students that went into family medicine went up from 25% to 40% in 1 year. And we are continuing to work and address those issues over time, and expecting to see that number rise further. And I might just ask Dr. Gass.
Dr. Gass, would you like to add something to this?
So I would just support what David has said, and also highlight that among the work that we've been doing within the department is to actually increase our recruitment of community family physicians into teaching opportunities for undergraduate, for the students who are in medical school, as well as increasing their participation in the residency program, which we've achieved as we've added new sites over the last 5 to 7 years. So that's very important. The second is we're challenging our faculty to find ways to ensure that they are visible and tutoring and leading the education, as David says, to the early students in the first 2 years. And I think we've had some success with that, and the result is it did go up last year. We have further work to do on that, and we have a particular strategy in place to ensure that the family physicians who are able to take part in the undergraduate program, which means you do have to be adjacent to Halifax, are encouraged and supported to do that.
Ms. Martin.
So I guess 2 quick things then. First of all, is what year's the 25% from, that you say it was at 25% for students going into family medicine and went to jump to 40? And secondly, if this longitudinal integrated clerkship was so successful in New Brunswick, why are we just rolling it out in Nova Scotia now?
Dr. Anderson?
So the numbers, it was 2018 was the residency match when it was 25%. It was 2019 where it was went up to 40%. The longitudinal integrated clerkship started with the inception of Dalhousie Medicine New Brunswick in 2010. So we made the strategic decision that we were going to start this program from day one with that medical school site in New Brunswick. It was a novel and innovative thing for us to do. We wanted to see how it worked, whether it was well accepted by the students and by the communities, and it has turned out to be a phenomenal success. It takes time, however, to get this program in place. It usually takes 2 years by the time we decide that we want to do this in order to get the program up and running. We've got to identify physicians that are agreeable to taking the students on as preceptors. We've got to ensure that the resources are available within the communities to manage these programs. And so there is usually a 2-year time lag in getting new programs up and running. So that is those are the factors, just the reality of dealing with these comprehensive programs. And when I became dean in 2015, I started working on implementing this program shortly after I took over as dean, and we've been working with the Department of Health and the Department of Labor and Advanced Education to get the logistics work out, and then we started negotiating with communities. So it is moving forward in a timely manner, and I think success in Cape Breton is going to solidify success in other places around the province.
Ms. Martin.
Thank you. So I wonder, keeping along those lines, how is this successful in recruitment and in retention? And to that end, when students are not choosing to stay here, what is it that we're missing with recruitment and retention? What other offers, what could we be offering them in order to stay, or why are they turning down our offers?
Dr. Anderson.
So I think it's important for the committee to just be aware of the distinction in our 2 different training programs. So we have an undergraduate medical education program, which is for 4 years, and students become doctors at the end of that. They then enter residency training programs where they will become either family physicians in a 2-year program, or they will become specialists in a 5-year program. So the longitudinal integrated clerkship program that I mentioned is in our undergraduate training. It is the 3rd year of their training. And again, the value of that program is it is highly likely that students that come out of that program are going to work in the community setting when they're finished, usually in careers in family medicine or in what we term generalist specialties. And then there's the residency programs. So again, with the strategy that we're doing, encouraging our students for a career path in family medicine, increasing the size of the medical school in Nova Scotia, increasing the number of residency training positions, and then having very high rates of retention of students and residents that go down that path is going to help us address the current shortage that we have of physicians in the province.
Ms. Martin, with 2 minutes.
Thank you. The Canadian medical student graduates with a debt load of more than $160,000. We know from Canadian data that students with higher debt loads are more likely to cite financial considerations as a major impact on their practice location and specialty. In your opinion, is there adequate funding in place to ensure that more doctors choose to practice family medicine in Nova Scotia?
Dr. Anderson.
So there are active programs in Nova Scotia to financially compensate our graduates that are going into family medicine, particularly in the community setting, and I can provide you with that information. And these are not our programs. This is from the Department of Health and Wellness in offering loan forgiveness, bursary programs to support students going into practice, particularly in community settings in the province. And those factors are important to our graduates, and I completely agree that it is a staggering debt load that some of our graduates are carrying, and support from the provincial government is absolutely making a big difference in helping those students make decisions to stay in Nova Scotia.
Ms. Martin?
Thank you. Is there something that we could be doing more to encourage doctors from Nova Scotia to practice family medicine financially or otherwise?
Dr. Anderson, 25 seconds.
I think one of the recent developments that I think is really encouraging is that communities are reaching out to our students and our residents and embracing them and exciting them about the opportunities to be able to come and work in communities around the province, and initiatives like the Lunenburg Now.
Order, please. We'll now move on to the Liberal Caucus and Minister Kasoulis.
Thank you, Mr. Chair. Thank you to my colleagues for allowing me to stay here today. It's actually my first committee, so it's actually quite exciting for me because I've never had a chance to or opportunity to experience committee work, and being a health committee is very important not only to myself but to all the MLAs in the legislature. Dr. Anderson, thank you for being here today. I wanted to follow up on some of the questions that my colleagues asked, just to help us get some better insight into family medicine and specialty. And I realize that you're with the school, and you might not be the best person to answer this, but perhaps you could give your opinion on what is the ideal percentage that our family doctors, out of all of our doctors graduating, should make up for moving forward in the province to meet the needs of both specialists and family doctors.
Dr. Anderson.
So in my opinion, and about a 50-50 ratio, I think would be a very good target for us to achieve, both for graduates and for physicians in the province.
Mr. Kasoulis.
And on that, do you feel we'll get to the 50-50 by next year, the year after, with the changes that have been made? When do you think we might see that, or when do you track that within the school of when you anticipate that would happen?
Dr. Anderson.
So I waited that time on. So our target is for 2022 that we're going to be 50-50 graduates of our medical school. The fact that we jumped from 25 to 40% in 1 year makes me guardedly optimistic that we may be there a bit sooner, but some of the other changes that I discussed earlier are going to take not take time to have effect, but it'll be impacting first-year students that then will be 3 years before they'll be graduating. So I think to see the true benefit of our efforts is going to take 3 years.
Minister Kasoulis.
Thank you, Mr. Chair. I wanted to move on to another topic, and I think you could provide us some great insight into it. I'm not sure if, I know it would cover the school as well, possibly the college. I want to move on to international doctors, and perhaps you give us some insight into why some international doctors can come into the province very easily in practice, but other ones we don't accept, and they have to almost jump through hoops. And you know, I'm assuming that it's the difference within the education that they receive at various medical schools by country. And then I'll follow up to that questioning.
Dr. Anderson.
So again, it is the Provincial College of Nova Scotia that makes decisions around licensing physicians. It's not a university function, and I just caution the committee that I have peripheral knowledge of this as a former department head that was involved in recruiting physicians and that sort of thing. But there are others that can give you a more complete answer here. That a major factor is around the credentialing of those physicians when they come to Canada, and where they graduated from internationally. So there are some there are some countries where there is what might be termed reciprocity around acceptance of their specialty designations in a country. So, for instance, the United Kingdom is one where the training program is quite closely aligned with what we have in Canada. So, physicians that graduate through that rigorous model of training, their specialty credentials are generally accepted by the province. And then the those physicians have to pass examinations when they come to Nova Scotia, come to Canada. There are Canadian licensing examinations that they have to pass in order to receive a license. So that one of those two factors is may be impacting the ability of international graduates to receive positions here in the province.
Minister Kasoulis.
And so with that, is there, for other countries where we might not accept the level of education on par with what we have here in Canada, is there, I know you had mentioned that some international doctors are accepted. I'm assuming they're accepted from countries that have equal reciprocity. The countries that don't have equal reciprocity, is there any steps that we could do in the province, or are there any other universities that offer a shorter program that you're aware of maybe in Canada that allow those doctors to come back, perhaps upgrade their skills for a shorter period of time, and then we can move them into a residency and have them practicing in Canada?
Dr. Anderson?
So there is a program now that has been developed in collaboration with the College of Physicians and Doctors Nova Scotia, which is called the Practice Ready Assessment Program in the province. And Dr. Gass was instrumental in developing that program for family physicians. And I might ask if he could speak to that, Minister Kasoulis.
Dr. Gass?
Thank you. So the program is aimed at those countries where the physicians who have trained and practiced in those countries have a training program that looks similar to ours, and the practice in the community is thought to be somewhat similar, but it's enough different that the college looks for reassurance that they are in fact ready to practice. And so we're working with the college to make sure that those who would basically meet their sort of documentary requirements can come in and then move into a community practice where they will work in two different communities with two different preceptors who over a 6-month period would evaluate how ready they are to actually practice well in Nova Scotia. Obviously in 6 months they also learn some skills and do some adaptations. And if at the end of that 6 months the preceptors judge that they are ready for practice, then the college has indicated that they would be offering them licenses as other graduates from the recognized countries would have, and they have to then write the other exams to confirm that ability and that certification in the country. We're in the very early stages of that. We have the first group of international graduates who have written a therapeutics exam and are now looking at being assigned to communities for assessment. We hope that as that program evolves, we've planned for a capacity of entering 10 such international graduates each year. So it would be a significant addition to the physician supply in family medicine. I know other departments are considering how they might do that in some of the Royal College specialty disciplines, but we're focusing on family to start with.
Minister Kasoulis.
That's encouraging news. When do you think we might be up to the 10 family doctors per year? Is it within the next year or two, or would it be a longer time frame to get up to that number?
Dr. Gass?
Sure, thank you. We expect it will be about probably 2 years. We're not sure that one of the limiting factors is being clear what the credential requirements of the college are in order to enter the assessment period. And we're just kind of testing that market as we speak. We're also not well known yet among the international community, so we hope that as the program has some success, that will increase. I'm a pathological optimist, so I would aim for 2 years, and we might take a bit longer. I'm less cautious than David, perhaps.
Minister Kasoulis.
And my other question, you spoke about the 4 international medical physicians that got residency here in the province. Pardon me? Could you tell us which countries did they come from? And I'm assuming that, again, it was equal reciprocity in terms of training at the medical schools there.
Dr. Anderson?
I can get the committee the information as to what countries they've come from. I don't have that with me right now.
Minister Katsoulis.
And as well, we spoke about our non-Dalhousie residency. Our retention rate in family medicine was approximately 50%, which was a lot less than Dalhousie's. Have we done any analysis into why that would be? Does it fall solely that Dalhousie would have more Nova Scotia students who would want to remain in Nova Scotia, or would there be other factors for those resident students come here? And do we even do any exit interviews upon graduation that we get more insight into this to help our numbers in the future and to increase them?
Dr. Anderson.
So again, I think that's a very good question. In our discussion with the residents, it is often the tie from home that will pull those residents back, and if they have opportunities elsewhere, then and particularly from their home province or home city, they often take them. And I think, as Dr. Gass has said, the other factor, there is a calling home of Nova Scotians. So we do get physicians coming the other way, but once a non-Nova Scotian leaves the province to enter practice elsewhere, they're not likely to come back to Nova Scotia if they don't have family ties here.
Minister Katsoulis.
I'd like to thank you for all the answers, and I'll pass it on to my colleagues because I know they're eager to ask some questions as well. Thank you.
Mr. McKay.
Yes, thank you much. Thank you very much, Mr. Chair, and thank you very much for a very enlightening program. It's interesting. I note when I was first considering getting into politics that there seemed to be quite an uproar about the wait times and so forth regarding orthopedic surgeries in Nova Scotia, and now it seems that we've reached the turning point, the inflection point, and we're actually doing pretty good and trending probably middle of the pack in the country from previously being the worst. And now I see some similarities here with the efforts that you're making with your partners in government, with the health authorities and the college and so forth, that we're reaching a turning point in family physicians as well. And no doubt in another 5 years, there'll be another thing that we're in here discussing. One of the questions that I get asked a lot in my constituency is, why can't you add more seats to the residency programs? Why can't Dalhousie accept more? And I'd like to get some good, credible statements I can use when I'm speaking to my constituents on that.
Dr. Anderson.
So so thanks for the question, Mr. McKay. I just, as I've said earlier, this year we have added 25 new seats to our residency training programs, and those are 25 seats that will compound over time. The 15 specialty seats will be 75 new residents in those roles in 5 years' time. And the 10 new family medicine positions, that's a 2-year program, so that will be 20 a year starting next year. That is a very substantive increase in residency training capacity in the province. That is going to make a big difference in our production of family physicians and specialists, with a focus on meeting community need. All of those family medicine training positions are outside of Halifax. Those 15 residency positions were designed to meet the need where we have gaps in specialty training positions in this province. So that is that is a very, very substantive investment by the province that we are very grateful and very much look forward to seeing that implementation over the next 5 years.
Mr. McKay.
Just as a follow-on to that, I guess when I'm explaining to my constituents on this, some of them will say, well, why don't you just double the number of seats? Why don't you triple the number of seats? Why don't we do this immediately? And I know you've provided some narrative to that today, but could you go a little deeper on that to help me out? Dr. Anderson?
So there are capacity issues in what we can do and what we can train. So that 25 new residency positions is a huge undertaking for us in our Department of Family Medicine and in our specialty programs to take on this increased teaching workload that our faculty will have to do. And we are held to an incredibly rigorous accreditation standard of both our undergraduate and postgraduate education programs to ensure that there is no compromise of the training opportunities of existing medical students or existing residents by taking on this additional work. So it'll give us, it'll probably take us a year or 2 or 3 to see how well we are able to absorb this very large increase in both in undergraduate and in residency training capacity, which again is a great opportunity for us in the Faculty of Medicine. We're very, very excited by this. And when we have a chance to see how it goes, we will have ongoing discussions with our partners in the Health Authority, the Department of Health and Wellness, and Labor and Advanced Education, and look at how are we doing, where are our biggest training needs, where do we need to course correct over time to have the biggest impact and make a difference to the health of the people of this province.
Mr. McKay. Thank you for that, Dr. Anderson. One of the things that you mentioned in your preamble was the need for inclusion, and that we were looking to try to bring in greater numbers of African Nova Scotians, Mi'kmaq, and so forth. Could you speak a little more to that, please? Dr. Anderson.
So that has been a focus of our medical schools, particularly over the last 8 years. So we do have what we would term an affirmative program that if students from Nova Scotia of African descent or Indigenous students meet our minimal academic eligibility criteria, they automatically are accepted into our medical school program. So and there is no quota on this. We will take as many students of Nova Scotian students of African descent or Indigenous students that meet our eligibility criteria. So over the past 8 years, we have had 30 Black Nova Scotian graduates and 20 Indigenous graduates in our province. We did not systematically track the number of Black Nova Scotian and Indigenous students prior to that, but historically, over 50 years, we probably had less than 10 of each coming through the medical school. So it is a sea change in focus in those particular areas. Unfortunately, though, we've identified with our Mi'kmaq community that we have not been successful to that program in recruiting status Mi'kmaq students from Nova Scotia. So we require a different, a more concerted approach to be addressing the Mi'kmaq population in particular, and that is a major focus of our efforts right now, is looking at making changes to enable us to be able to recruit status Mi'kmaq students to our medical school.
Mr. McKay, with about minute 15 left.
15? Okay, thank you very much. I also appreciate coming from I guess in my case, a semi-rural part of Nova Scotia. As my colleague from Pictou West has mentioned, we have an acute need perhaps for rural family physicians, and I'm glad to hear of the steps that you're undertaking. Does DAL work hand in hand with NSHA on recruitment strategies and bringing potential those students who might be interested in seats at Dalhousie to work in rural areas? Do you work hand in hand with NSHA on that?
Dr. Anderson, 30 seconds.
So I'd say yes, and I might ask Dr. Gass to speak about that as being more directly involved with the family medicine resident recruitment.
Dr. Gass.
Thank you. Briefly, we've increased our connection with the NSHA recruiters in a strong way with each of our sites, so that all the residents in those sites have a chance to be approached and be made aware of the opportunities that are existing in those communities and in other communities. An issue for recruitment sometimes is partner employment.
Order, please. Well, now that concludes our time with the Liberal Caucus. We'll now move to 3 rounds of 10 minutes. Although no one caught that I actually cut off 5 minutes from the NDP's time. So I will correct that with going 10 minutes to the PCs, 15 minutes to the NDP, and then back to the Liberal Caucus for 10 minutes. I hope that's satisfactory to everyone. So to Ms. Adams.
Thank you very much. I'm going to turn things over to questions of income for physicians in the province. The Nova Scotia Physician Resource Plan said that we need 1,000 new doctors by 2026, 500 family medicine, 500 specialists. And we were hearing numbers from you in terms of how many Nova Scotian graduates were turning towards family medicine. I want to make it clear for those who are watching that it's your job to train really highly trained physicians, and you're doing an excellent job. And I'm a former Dalhousie grad myself in healthcare. So I think it's really important for people to understand that it's your job to train physicians, but it's the Department of Health and Wellness's job through funding and other initiatives to ensure that we have enough physicians in the province. And one of the things, sort of the elephant in the room, is the fact that the #1 reason I hear most quoted as to why medical students aren't staying here or coming back is they're just frankly not paid enough. And we know that Nova Scotia physicians are paid the lowest salary in the country by far. Newfoundland is next at about 4% more than us, all the way up to Ontario, which is 40% higher. So I wanted to remind everyone that Alberta is now the nation's highest paid physicians get $380,000 a year, and they don't have the same recruitment issues. So I just would like you to comment on the fact that our physicians in this province are the lowest paid, and how you believe that that impacts medical students' choices, because we can train them and provide them with teaching opportunities, and we can give family doctors pay to actually come into the universities to teach and fund them to do so, which is fabulous. But if there's no financial incentive to stay here, then the worry is that we've got a whole lot of highly trained Dalhousie graduates who are leaving to go elsewhere. So I'm wondering if you can comment on the wage disparity and how you think that that impacts students' willingness to stay in Nova Scotia.
Dr. Anderson.
So thank you for the question. There are many factors in decisions that physicians make around recruitment and retention. Money is one of those factors, and there are many others. Quality of life, opportunity to practice the type of medical care that one was trained to do and is passionate to do are other factors. I think the success around the recruitment and retention of Dalhousie graduates, and particularly focusing on family medicine, which is the greatest area of need in the province, has been pretty impressive over the past 5 years. So our strategy of increasing the number of medical school seats, increasing the number of residency positions to recruit and retain physicians in this province has been shown to be very successful. So I think there are a number of factors involved in recruitment and retention, but the fact of having excellent positions in communities where these residents have had the experience of being able to be trained and embraced by those communities, those are very important factors in their decisions to stay in the province. And over 80% of our Dal grads trained in family medicine positions are staying in the province.
Ms. Adams?
Thank you, and I was reminded of another comment that had been made earlier by another member that we were in the middle of the pack with respect to orthopedic wait times, and that, frankly, is not something that I believe is the current belief. As a physiotherapist working in that industry for years, our wait times for orthopedic surgeries are still the worst, with the exception of if you fracture a hip. The Nova Scotians in this province with between 50 and 100,000 who are waiting for a family doctor, that number has not significantly changed over the past 5 years. So despite all of these initiatives and changes that are occurring, there are still far too many Nova Scotians without a family doctor. So, and in particular in rural areas like Yarmouth and Cape Breton. So I'm wondering if you can tell me, with the change in the announcement for new seats, with a significant rural focus, can you tell me how many of the 16 seats that were announced are going to be reserved for students coming from rural Nova Scotia? Because we know that when you come from a rural community, you're more likely to go back.
Dr. Anderson.
So we are going to be using the 16 new seats to balance the number of students that are being admitted to medical school between urban and rural communities, to make sure that our student numbers are aligned with population-based numbers of our communities. And so potentially all 16 of them may be focused on recruiting community graduates, just depending upon the numbers of admitted students for that particular year.
Ms. Adams?
One of the things that's currently happening is we've moved from the fee-for-service and the alternative payment plan, and now we're waiting for the blended model that's coming. Between that change of a blended model of payment, the tax changes that happened federally that further cut back on a physician's take-home pay, and the changes with collaborative practices so that there are now clinical nurse practitioners who are taking over some of the workload. Have you heard from medical students their concerns about how they may be paid in the future in this province? Because right at the moment, they're still waiting for a contract to be signed. Are you hearing concerns from medical students about the pay structure and how that's happening in this province and the fairness across all of the regions in Nova Scotia?
Dr. Anderson?
So again, you have to appreciate that medical students are years away from where those are going to become issues for them. So it's not a top of mind discussion amongst medical students about how they are going to be paid when they enter practice. Ms. Martin asked earlier about the debt load that students are carrying when they graduate from medical school. That is certainly a concern for them, and being able to manage their debt and get rid of that in a timely manner is their concern.
Ms. Adams?
Thank you. I as a former health student, I can tell you that I knew what the pay structure was for every province across the country, and it certainly impacted my choice of where I wanted to work. So I think that it is an issue for all medical students. The other question I have for you is the respect that family physicians in this province get is sometimes lacking. And I think that people fail to appreciate that they are a medical specialty in their own right. And so I'm delighted that the family physicians are now being paid to help teach, because I think that shows them that respect, and I hope that is expanded across the province rurally. I'm wondering how your department works with the Department of Health and Wellness to track the gaps in services across the province, and whether that's how the gaps have changed over the last few years in terms of making sure that there are sufficient physicians who are in family practice versus specialists versus hospitalists versus the researchers versus the academics. Just wondering how you're tracking those gaps in services.
Dr. Anderson, we've got about a minute left.
So first, I'd like to say I completely agree with your first comment that family physicians are an incredibly valuable part of the health system in the province. And as primary care providers, they are the backbone of healthcare in this province. They are specialists. They are special in family medicine. So completely agree. And with the shortages of family physicians, and particularly with the number of patients that do not have family physician, every physician in the province appreciates the value of having family doctors, and that in part relates to our commitment in training more family doctors in our programs. We do have a committee that consists of our people from our shop, our residency training directors that meet with the Department of Health officials, with labor and advanced education officials, and those from the health authority to talk about where we need residents, where we need to make course corrections in our residents.
Order, please. Our time has elapsed for the PC caucus. We'll now move on to the NDP caucus for 15 minutes. Ms. LeBlanc.
Thank you very much, Mr. Chair, and thank you for being here. I'm enjoying this discussion very much, and I was particularly interested in your response to somebody's question about, your consultation with the students and why their responses to why maybe they weren't going into family practice specialties. I appreciate all of those answers, and they make sense to me. And I'm sorry, I didn't actually hear your question regarding family practice versus specialty. But what I was going to ask is, has there ever been consideration of words and titles? Because words are powerful, and I know that when I was a young, junior high, sort of high school student thinking about wanting to be a doctor at one time in my life, that was a long time ago, I always heard about specialists, and well, we call them family doctors or general practitioners, and they're very separate things, and I'm even doing this, like there's this and there's this, but they are this, right? And Hansard's not going to understand that, but I was making a motion to explain that they should be on the same level. And I wonder if there's ever been any consideration of changing the language around family practice physicians versus specialists. Is there a way to rid our lexicon of the word specialist in place of something else, or to include the family practice specialists or something like that? Is that ever a discussion that's had?
Dr. Anderson.
So we had just that discussion yesterday in preparation for meeting with you today. And again, as like Ms. Adams' question, family physicians are specialists and they are special. And some family physicians do additional training after family medicine to focus in a particular area. And we absolutely need these physicians to ensure that our healthcare system works well. And so I think that any consideration that there's a value distinction by calling one group family medicine and another group specialists, I completely concur. It's a problem, and certainly with our students, we want to give them that message that family physicians are very special and they are specialists, and this is a career that is absolutely worth pursuing, and the most important need that we have in society right now is to have more of our graduates going into family medicine. Again, I might just ask Dr. Gass to comment, because I know he feels passionate about this as well.
Dr. Gass.
So I think it is an important issue, and it has been talked about and is agreed at the national level that the College of Family Physicians consider their graduates and the people they certify as specialists in family medicine. And so the biggest language challenge is to actually just turn them around and talk about family physicians and other specialists. And that would be the simplest way we could do that. I think the important thing, language aside, though, is that in the last few years, it's also become apparent that more and more people have appreciated that family physicians are a key element in the healthcare system, along with our other specialists from other disciplines. And it's been encouraging to hear that reflected from our colleagues as they experience the difficulty of the shortage of family physicians and the impact on their specialized practices. So it is important, and it is relevant, and it's important in attracting students so that they see this as a career that's as central to the healthcare system as any other discipline.
Ms. LeBlanc.
Thank you. And I was also wondering a little bit, I understand that in Nova Scotia we have a real need and a real concern around family practice in rural areas. And I'm glad to know that a lot of the new the residency programs are focusing on rural areas. I come from constituency that is very urban. So there's urban and then there's urban. And then so like in my riding, we have an extremely sort of dense core of people that are in extreme need. We have very high social and material deprivation. We have high levels of mental health and addictions issues. And we have, well, I could continue on. We have a huge amount of people in core housing need, for instance, or precarious housing, lots of homelessness, issues around homelessness. I'm wondering if there's anything in the specialty of family medicine that focuses on like inner city core or urban core issues particularly, and if that is that a focus for Dalhousie?
Dr. Anderson.
So again, I think that is a very important area, and I would just ask Dr. Gass to comment on that if he would.
Dr. Gass.
So historically, the focus on the need for family physicians has been rural. In the last few years, we've become apparent that there are also urban needs, and that they may look somewhat different. They may be focused on the social determinants of health that you identify. And so in our program, we have a significant urban-based part of the program. We in that program, it allows us to focus on some of the issues around how do we, in fact, identify people who are housing or income challenged, and then how does our program respond differently to them. So that is a curriculum discussion with us, as well as an operational discussion for the clinics that we manage. I think if we were to look at expansion, as we increase the needs, we see where we are short, it would seem that there are some urban communities that probably equally with other rural communities would be on the list of where might we expand and support practices that address those particular issues. And we have in our program, and some folks are in fact attracted to the Halifax component of it because they are interested in addressing the challenging urban health issues that primary care and family medicine experience. And so it's very much on our radar. It's a curriculum issue. It is a discussion about, as we anticipate potentially increasing further, whether in fact a focused urban program, perhaps on the other side of the harbor, would be an important place to be. That does highlight then the challenge of finding the teachers and finding the settings and the team-based care that match well the community's needs, which is where those kind of learning experiences should be. And that also is an active discussion with the health authority, where we recognize that our residents are hoping to work in team-based settings as they graduate. So the more we expand and find those and develop those and include them as teaching sites, the more successful we'll be.
Ms. LeBlanc?
One of the stated, in the hashtag DalMedForward strategic plan from 2016 to 2020, under focus area 4, you've stated a goal of enhancing the health of Maritimers through excellence in education. You say that you'll know that you're succeeding in the long run, or the longer run, when Dal learners across the continuum have accelerated the, quote, transformation needed in healthcare delivery, end quote. Can you talk about what that transformation is, and what is the system now and what it should look like in the future, in your view?
Dr. Anderson.
One of the important areas in around system transformation is leadership, and what we would like what we what we promote in our graduates is that they be leaders in healthcare in addition to being excellent practitioners. So to be taking leadership roles, whether they be within clinics, within systems, or at a provincial level, is something that we'd like our graduates to aspire to do at an early stage of their career, not just saying after 20 or 30 years of practice, you're good enough now that you should be moving up and becoming an administrator. So it's getting our students and our graduates engaged at system problem solving in addition to providing excellent care to individual patients is part of that transformation.
Ms. LeBlanc?
And so my question written here is, what is the role of the medical school in that transformation? Are you actively thinking about how you approach that with students right now in the curriculum planning?
Dr. Anderson.
Absolutely. So we're looking at what's the role of the students in leadership, what's the role in teams, and a lot of focus in medical school now is on interprofessional education. So how do physicians work well with healthcare providers, nurses, physiotherapists, occupational therapists, social workers, pharmacy, et cetera, in delivering team-based care. And in addition, it's providing experiences in the communities, having our students being able to see what are the issues and challenges in rural areas is another very important facet to this. We also have what we term service learning programs. So all of our students have the opportunity to participate in programs that deal with often deal with socially disadvantaged people in our region. And there are one clinic is called HOPES, which is an interprofessional student-led clinic focusing on the care of disadvantaged populations. And there are many other programs where our students perform what would be considered volunteer work, although it's part of their curriculum, to work with disadvantaged peoples, addressing social determinants of health, addressing literacy issues, volunteering in other ways to contribute to society. These are all very important parts of the fabric of the medical school as we look to create the leaders of the health and the health system of tomorrow.
Dr. Gass.
Thank you. That's an excellent question, and I'd just like to respond that in the family medicine program in our sites throughout Nova Scotia, in fact throughout the Maritimes, our residents are encouraged to actually look for a community need or community charity that they can contribute to as members of that community, in recognition that the community is in fact supporting their education, that they should give thought to giving back, and the residents have been outstanding in their interest in that, in their engagement with the communities, and one of the side effects of that, or the outputs, is that the communities are also recognizing the residents as a major contributor within their environments and stepping up and encouraging and welcoming them and returning that support. And I can say that to and fro of engagement with the communities is a key recruiting action to good effect.
Ms. LeBlanc, 2.5 minutes.
Oh boy, thank you. Can you talk a little bit about the Tier 2 Canada Research Chair in primary care, what the status of it is? Can you talk about what kind of research will be conducted and how that research will interface with the Nova Scotia healthcare system?
Dr. Anderson.
So maybe I can start and Dr. Gass can also comment. So that will be a research chair that will be performing evaluation of primary care delivery in this province. And that we look to see that position being very closely integrated with the Nova Scotia Health Authority in particular, and working at collaborative, the evaluation of the various models of delivery of primary care that we're doing in this province. We want to know what works well, do more of it, and what is not working so well, we want to replace it with a better system. But that is a very important strategic research position that we're moving through the recruitment process at this time. And I would just ask David to comment as well.
Dr. Gass?
So thank you. This is an exciting development for our research unit in the Department of Family Medicine, and it has had as its focus to date looking at the health system and its impact on outcomes and the things that determine the effectiveness of primary care interventions, including family physicians. The Canada Research Chair would enable us to strengthen that ability to get actual data information about the effects of how we operate within the system, analyze that critically, and then apply it in partnership with the health authority to future directions as the move towards collaborative team-based care evolves. So this is an exciting opportunity, and it is at the focus of the direction for our research unit in the department, of which we're quite proud.
Ms. LeBlanc, 30 seconds.
We're often hearing that medical graduates have different priorities. The new generation has different priorities than their forebears. Can you speak to what you're hearing from medical students about the expectations about practice in when they graduate, and how you feel that the school or the government should be responding to these new values?
Dr. Anderson, 4 seconds.
So yes is the answer, right?
Thank you very much. That concludes the time for the NDP Caucus. We'll now move on to the Liberal Caucus. Ms. Miller.
Thank you so much, Mr. Chair, and thank you both to Dr. Anderson and Dr. Gass for being here today. During your comments and the answers that I've been hearing from your questions, sometimes I want to sit here and applaud, although it's not appropriate for this chamber, but it really seems that, you know, we have a new path. You know, that things are really looking up in Nova Scotia. And, you know, I know that sometimes we hear so much negativity, and I find that sometimes that's self-fulfilling, that when you start talking the down game, you know, that becomes the narrative when we should be looking at the positive. I, too, am an optimist, so I'm trying to look at the positive all the time. So thank you for that. So my first question is, how many students every year apply to Dal Medical School compared to how many, you know, what percentage actually get in compared to what applies?
Dr. Anderson.
So it does vary from year to year, but there are over 1,000 applicants would be a typical year of students that would apply. Now, that is students across the country and even internationally receive applicants that are not eligible for coming to Dal. If we look at Nova Scotians that apply to medical school, last year was about 250 Nova Scotians applied to get into Dalhousie Medical School. And if we just walk through what happened to those applications, about 150 of those 250 met our minimal eligibility criteria. So they had an adequate grade point average, they had an adequate score on the standardized test called the MCAT score, and there was another standardized test that we do looking for traits of empathy and collegiality, collaboration, which they also have to take. So 150 students got through that phase, and they were offered an interview. All of the students that meet our minimal eligibility criteria from the province get an interview. 120 students passed through the interview process and then were eligible for admission. The Black students, Nova Scotian students of African descent were given admission. Students of Indigenous background were given admission, and then there was a ranking of the remainder of the students and the top ones got into medical school. So if you just sort of do the math, it's about 50% of students that have the minimal academic requirements actually get into medical school. And we'll see what the impact is of these additional 16 seats, and it possibly will mean more students will apply. We make the point that it is very achievable for Nova Scotian students to get into Dalhousie Medical School, and 1 in 2 that are academically eligible are offered a seat. 50-50 is many people have a myth that it's 1 in 100 or it's impossible to get into medical school. That just is not the case, and we strongly encourage students that are interested to work hard and to apply when they have the opportunity. We'd love to have them in our campus.
Ms. Miller.
And thank you, and that's really good to know because my perception was a little bit off on that as well. Now, when you're talking about the internationally trained students that are coming in or applying to come in for their third and fourth year, possibly that they had applied to Dal and didn't get in, maybe went to Saba or went somewhere else, how many of those students actually apply to get in that small window of acceptance there?
Dr. Anderson. I'm sorry, I don't have those numbers off the top of my head, but I can get those and provide them to the committee. Yeah.
Ms. Miller.
Yeah, can you tell me what the GPA is for students? What is the requirement for students who want to come into medical school?
Dr. Anderson?
So the minimal GPA for Nova Scotian applicants is 3.4. So that applies is somewhere between a B+ and an A- if you're using those metrics, or around the 80th percentile if you're using a numerical score.
Ms. Miller?
Yeah, and just shortly, more of a comment than anything, we were talking about international doctors coming to Nova Scotia on recruitment, and I think the last figures are that 42 have applied on our immigration stream. So that too, if those doctors all enter our system, however which way that they do it, will certainly be in addition to that. I want to thank you so much. It's been very enlightening today, and I regretfully have to pass this on to my colleague. Thank you.
We'll move on now to Mr. Horn.
Thank you so much. I've been listening here very intently, and on this issue, it seems to be a #1 issue for Nova Scotians is having a doctor. Not until the second last speaker mentioned about collaborative care, that word hadn't come up all day, and I was wondering if you could go a little bit into where the university stands on collaborative care. You may call it something else, and I think you have. Inter specialists and so on. But I think collaborative care appears to be, to me, the most operative way to operate now. There's like 17 new clinics coming up that seem to go by that collaborative care, and really wasn't something we had in the past, although there was something probably close where you have many different disciplines involved in a clinic. I wonder if you can comment.
Dr. Anderson?
So as I said earlier, it is certainly how we're training our students in looking at interprofessional opportunities and looking at working in teams and functioning in teams. And as they move into residency, it is that is the same paradigm, training paradigm that they and for many it's what they're expecting to do when they graduate. It's how they trained. It's how they want to work. But I would like Dr. Gass to comment, as this is near and dear to his heart as the head of family medicine.
Dr. Gass.
Thank you. So this is a key element of the future as we see it, and it's clear that our students and residents are expecting to work collaboratively with other providers in providing primary care. And in fact, many of our settings already are team-based, where the residents are learning. Our goal is to take that a step further and make sure that there are learners from all disciplines practicing in the same environment, so that you have that peer interaction occurring at the learning level as well as at the service and care delivery level. And so we're actively working with the Faculty of Health and particularly the School of Nursing to achieve that for nurse practitioners and family practice nurses, along with our family physicians. And we're working with the health authority as they establish collaborative primary care teams to ensure and encourage them to make sure that as they develop those, they're anticipating that they will be teaching teams, that they will have space for learners of all disciplines, have the kind of technology that learners expect to be available now to help them with their learning, and that we have the, I think I said space, and the teaching support for the other providers who can act as as teachers, as physiotherapists, as nurses, nurse practitioners, or any of the variety of health professionals who could reasonably be part of a primary care team.
Mr. Horn, minute and a half.
A quick question then on the flexibility of government to work on new strains of training for our new medical students and so on. Do you see the flexibility there in government to be able to increase, help increase the number of doctors in Nova Scotia? Or are we out of that area and that's totally in the Dalhousie or medical school?
Mr. Anderson?
So I would just say it is a necessary collaboration. The medical school needs to work with the health authorities, needs to work with Doctors Nova Scotia, needs to work with government. And we do have the structures in place to review that on a regular basis and making sure that our graduates are meeting the needs of society, and that our training program and numbers, that we have it right. And we do course correct to, if we do have concerns, we need to place more emphasis in one area than in another. So, and David, if not sure if you have additional comment.
Dr. Gass?
Sure, I think that matching our training capacity to communities' needs is the key discussion that's going on. And I would say that in our experience, both the Health Authority and Department of Health and Wellness have been willing to enter those discussions and are interested in understanding the challenges and the implications of making those kind of changes and making sure we have the right numbers. That's an ongoing discussion.
Order, please. That concludes our time for questions. I'd like to thank all members for their questions today and our witnesses for their responses. I'd like to give our witnesses 1 or 2 minutes if they'd like to make any closing remarks. Dr. Anderson?
I think I'd like to just sincerely thank this legislative committee for asking us to come and speak with you today. We think that it is really wonderful that you recognize that the Dalhousie Medical School in particular does have an important role in health and healthcare delivery in our province. And we are very committed to be working with our partner organizations to make this healthcare system work. And I would want to leave members of the committee with the assurances that we do meet regularly and effectively with our partners in the health authorities and within government to work to ensure that decisions that are made are in the best interest of the people of the province of Nova Scotia. I do want to thank my colleague, Dr. Gass, for coming and helping me here today. And I think his insights were particularly important, given the importance of family medicine, the specialty of family medicine in our province. So, thank you very much.
Great. Well, on behalf of the committee, again, thank you very much for coming and sharing your knowledge and wisdom. You're important partners to all of us here in this province to be working with young Nova Scotians and other medical students from far and wide, and you're an important part of the solutions to healthcare that we're all working together to solve. So again, I want to thank you, and you may now be excused, and we have a little bit of committee business to get to. So thank you once again. Members of the committee, we've got a couple pieces of correspondence to deal with. We have a letter from Krista Grant from the NSHA in response to request for information on February 2nd. It's been recently circulated. Any comments? Agree to receive? Everyone's in agreement. Thank you very much. And then as well, you've got a thick document here, which is a response to follow-up questions from the meeting of May 14th. And lots of information there. Comments on this, Ms. Martin?
Thank you. And I would just like to state for the record that is not the information that we requested. We will go after it in another way, but there is clearly misinformation coming from that department on who was part of the original committee.
Okay. Do you want to clarify this with the clerk after the meeting, or is it something we should get into now? You're fine? Okay. Any other comments to this information? Thank you. Next item on the agenda is with respect to discussion, a difference of opinion on what one member stated and what another member interpreted from that statement. And I understand Ms. Miller has a comment with respect to that. A copy of Hansard from June 20th is there. Ms. Miller.
Thank you, Mr. Chair. I'm very pleased to be able to address the narrative from the last Health Committee on June 20th. On page 9 of the printout, I hope it's there, Ms. McFarland states it. She says, is it fair to say at this point, just a simple yes or no answer, that none of the 35 recommendations today have been considered for implementation within, say, over the summer or any time quickly? Further to that, she also stated later on, it's somewhat disappointing to see that my understanding anyway is that none of them have been implemented at this point. My response to that, I said I found it interesting that the PC Caucus has suggested that the government move forward with all your recommendations. I agree that that a lot of the recommendations you have made are really great, but usually the narrative is extreme caution, and I would question, it says on here collaboration, but I believe it should have been consultation, so I found that interesting. So I will retract the word all from my words, but I do reiterate my observation that it does seem interesting that moving forward with changes within 6 weeks of the report's presentation is unusual in a climate where changes are only considered after due consideration and careful consultation. Thank you, Mr. Chair.
Thank you, Ms. Miller. Any additional comments? Ms. McFarland.
Thank you, Mr. Chair, and I want to thank my colleague for addressing this issue. I think that the environment that we are in as politicians, we're all hyper aware of always being accused of saying something that we didn't. And my point was, as we look at page 22, verbatim what was said. My colleague here, I found it interesting that the PC Caucus has suggested that the government move forward with all your recommendations, as she has indicated earlier. And I think it's important that when we have constituents and Nova Scotians watching us here, that they completely understand what our intentions are. And there was nowhere in this, the date of this meeting that I indicated or suggested that all recommendations be implemented and move forward. So I accept that she will remove all. And again, I think that we have to always be very careful in assuming that we indicate to the public, since this is in the public domain, someone saying something that they didn't say. Thank you so much.
Thank you. I think that concludes this issue. I now would like to finish up with our next meeting will be on Tuesday, September 10th from 1 to 3 p.m. The witness will be the Department of Health and Wellness and the Nova Scotia Health Authority RE Collaborative. I will mention that, okay, yes, thank you. Collaborative practice teams and doctor recruitment and agenda setting. So agenda setting will also form part of that meeting, and so we'll ask each caucus to forward proposed topics to the clerk, Judy Cavanaugh, by August 27th. All right, and with that, the meeting is adjourned. Thank you very much.